Thank you for your interest in this FRCS training program, and we will discuss few things about this program, what is it, and uh, how it is different from any other programs, if available, of similar nature. To my knowledge, there is no program available online like an ongoing support for exam point of view. So, since you have done your part one and getting towards the part two, these slides will tell a little bit about how we can approach the exam. There is nothing wrong in taking the international FRCS as we discussed over the phone. It is well accepted, it is well respected. But if you feel that confident enough and if you feel better to get the exact exam, there's something like a vintage type of exam, nothing wrong in giving a good try for the FRCS UK based exam. There is always a small question on whether the FRCS UK based exam will be considered equal for CSER. I had a discussion with some of my colleagues even last week regarding that. They said yes, international exams and UK exams will be considered quite in the same par. Because the FRCS exam from the CSER point of view, where to get into specialty register, is only a small part of it. There is a big portfolio which accesses various techniques, publications, and few other things also. The advantage of taking the exam, especially part 2, is it covers the full wide breadth of urology curriculum. I wish this kind of strong urology curriculum is available in every examination board so that the candidates should be aware of what they are signing in and also the extent to which they need to prepare. For example, later today in the presentation, I'll be showing you how this curriculum works and how we can use the curriculum as like a working board to further make sure that we are finishing the portions appropriately. Not many students approach the FRCS Part 2 exam by using a curriculum. Mostly they will select a book, they will start reading the book, or they will go system wise. Say, for example, they will take cancers and take renal cancer, prostate cancer, bladder cancer. They go like system wise. It's nothing wrong in it. They will be still covering a lot of things in curriculum, but the curriculum is provided by especially the FRCS examination board with a idea to make sure that the students should aware what they are supposed to prepare. But unfortunately, none of the training program or even the books which mainly handle the FRCS portions is not using the curriculum as the main drawing board. The other thing is there are some rare questions which I will take as an example. Say, for example, how gentamicin works, how nitrofurantoin works. Sometimes, if candidates come across these questions, say, for example, in the infection table or maybe even in technology table, they do well, especially those who are doing courses with me. They know that these type of questions are possible, so they do prepare. But they always come out with a kind of a vagueness that why they are asking about ciprofloxacin, why they are asking about nitrofurantoin. So my answer is number two. These are the very common antibiotics you're going to use throughout your practice. So why can't you know a little bit more about the antibiotics, pharmacokinetics, what is the spectrum of coverage, what is the latest say for example MHRA release on any deficiencies of these medications or side effects of these medications. Say for example, recently we had a press release on the long term tendon weakness on people taking ciprofloxacin. So we have almost reduced using ciprofloxacin like 3 weeks 4 weeks for like chronic epididymoarthritis and few other conditions. So these kind of updates are useful. That is the second point. The first main point is I will show you in the curriculum. Obviously it is there in the curriculum. So once if it is there in the curriculum, because it takes time, it takes a group of subject matter experts to sit together, break the head to form the curriculum so that it's robust enough to make a very strong, good candidate. So why not follow that easy blueprint? That is the first reason why you need to follow the blueprint. The other thing is the when we are going for the OSCE exam setting, again it will be very closely following the curriculum. So people don't want to create a question outside the curriculum. And if at all, if there is a question which is present outside the curriculum, say for example, the newer BPH innovations like iTind, Optilium, if they are not in the curriculum, they will be creating a question, but obviously they will also update the curriculum to reflect. So both ways, curriculum will be a drawing board for the questions, and questions, if there is, it will reflect on modification of the curriculum. So either way, curriculum is the main thing to tick all the boxes, and the curriculum is designed so that you will know, even for your Caesar specialty registration pathway, it will be a very good drawing board to work on, because there are few other things apart from what you need to do for FRCS part 2. And in UK especially, there is a very good strong portfolio pathway kind of group supporting each other with some small mentorship programs, etc. There's a separate WhatsApp group for that. Once you are in a shape to apply the specialty registrar GMC, I will link you to that WhatsApp group so that you'll get enough support ongoing for that. Of course, everything we are doing as much as possible without any extra expenses. And this will improve your professional progression, both if you are in kind of an NHS type of a government setup or even in your private sector. And definitely the presence of FRCS improves the private practice wherever in the world. And it will help to relocate, as you are thinking of possibility of relocating to UK at one point possibly. It's better to do this at this age, so that it will be a quite handy thing at any time, rather than considering it at a very senior age. And it will also help you in your local exams, like for example American board exams, or FIBU if you are in Europe, or any other national board exams of countries like Pakistan, India. Preparing for FRCS will really make it a very good pass rate for the local exams. Sometimes the way by which the local exams handle the examination may be difficult, like long case scenarios where kidney cancer is discussed over 40 minutes, etc., while the FRCS pattern is slightly short and also sweet. And if you are a post FRCS, of course, if you take any other exams, if the examiner or the examination board knows that you are a post FRCS, that itself will give you a kind of a boosted platform to perform. How much time to prepare? I think you are very optimally placed. I will say a very good, nice, smooth, slow 6 months is the best way, so that you can enjoy the scenic route. You can have your own breaks. You don't have to rush away from your normal practice or family, like what we are doing, like a weekly once on Wednesdays. Once in a while on Wednesdays, it may not be suitable for me or you, so we have a break. Or to balance it out, we can do on that week instead of Wednesday some other days. And we can take, for example, we are going to take stone scenarios as the first scenario to start. So we'll take the stone scenarios, we'll work it out maybe for even 4 weeks and 3 weeks, and we have enough time to breathing in between. As I said again and again, strictly we will follow the curriculum. There are well laid out scenarios. Once you know the curriculum, you can prepare the scenarios yourself. For example, in the curriculum, if it says to know about the functioning of common antibiotics, you can easily prepare the scenarios, like how gentamicin works, how ciprofloxacin works. So scenarios can be easily prepared by ourselves. And there are three components for this exam: is the knowledge, application of knowledge, and how good we are in communication. Knowledge is the dry, mundane things which you have to read. Lot of areas where you may have to remember few things, remember some numbers, remember some quotes like references for the articles, etc. Application of the knowledge. This is where, say for example, if there is a scenario in the infection table where the examiner is showing you a patient with a kind of a scrotal cellulitis like appearance. So there is no point in you rushing to think like, oh, it may be a Fournier's gangrene, so I will be taking this patient towards the Fournier's gangrene. It's a wrong practice to think that this is a Fournier's gangrene scenario. That's another wrong practice. People always think like, okay, I wish to find out what scenario they are going to handle so that I can discuss the theory part of it. There is no need to discuss or find out what scenario is it. It's better to handle the questions question by question. So what I mean is sometimes the examiner may discuss like bilateral testis normal, just scrotal cellulitis in the ultrasound. What will you do for scrotal cellulitis if the patient is bed bound, a kind of scrotal support, and they may take you for a minute or two with scrotal cellulitis, and then you are following up the patient in 48 hours. You saw a black patch appearing in the backside of the scrotum, and then slowly they will take it to Fournier's gangrene. You can see how it goes on. There is no need for you to jump into Fournier's gangrene straight away. But having said that, even in the scrotal cellulitis stage of the discussion, you may have to mention one word stating that I will be very cautious about the possibility of this patient developing a Fournier's gangrene. So I will keep this in mind and look for it, so that the examiner is quite happy to see the application of the knowledge. And communication, this may not be a big problem, especially for you and also people who are taught in an English as a first language. But what I mean by communication is how you are engaging with the examiner, how you are making an eye contact, how are you using the gestures, how are you using the prompts in the table, like for example paper and pen. So those are the things which parts into communication, which we will discuss in detail as we go forward. So by now you may be quite familiar with this JCIE portal. So you know how to download the regulations, syllabus, and how to book the exams. You have done the part 1 already. So this is the curriculum part of it, which explains quite clearly the part 1 and part 2 patterns. So for example, part 1 section 1 has got 2 papers, which you know it's a single based answers. And for the oral exam, so let's focus on this one. So if you follow my arrow, so it's predominantly what we are doing is we are going to focus on these scenarios. So for example, there is section 1, 2, 3, and 4. So 4 sections. In the first section is predominantly oncology. So if you see here, this gives you an idea that oncology forms only 1/4 of the whole exam. A lot of people spend hours and days for oncology. Of course, we need to spend, there is no doubt in it, but we need to understand that the oncology as such occupies only like 1/4 of the whole curriculum. So we need to give enough importance to other things like pediatric urology and oncology and technology, etc. So pediatric urology emergency are given equal weightage compared to the oncology. So for example, if you are having the exams OSCE in the same pattern, then you will be starting with oncology. So first scenario may be kidney cancer or a bladder cancer. If you have a kidney cancer as a scenario, you may not have a bladder one. And in the second scenario, you will be having a prostate or a testis. So you may not have penis cancer at all tested throughout the exam. Very, very rarely you may get one scenario on testicular cancer, one scenario on penile cancer, and you may not be tested on prostate cancer. So after spending hours and hours on prostate cancer preparation, sometimes you may miss it throughout the whole exam. But having said that, repeatedly, the aim is not to just to prepare for the exam. The aim is to use this part to preparation as a good opportunity to get an overall confidence in the curriculum and the approach. Pediatric urology, I will be inviting another special guest during the pediatric urology section. So you'll be having the pediatric urology sections by a specialist who is good in pediatric urology. Obviously, I can do the theory part of it, but it's nice to have a proper practicing pediatric urologist for these classes so that they will give you the real-time practical applications. As I said, I can do the knowledge part of it, but the application of the knowledge should be from the specific specialist. Emergency urology, that can be covered, but others will be mostly covered by me. Calculi and UTI infections and urological imaging and principles of technology. Bladder dysfunction and gynecological aspects. Again, bladder dysfunction could be female patient, neurology patients, a lot of things can be covered there. BPH and andrology. So in essence, you will be having 4 main things, but it's type of like 8 scenarios, and every scenario you'll be having like two scenarios each. So you will be definitely having a kidney cancer and bladder cancer, but here you may miss one of the cancers. Okay. So are you confident in this overall idea? So this will give you a kind of a baseline about what you are signing in for. Any questions? You want to stop anytime?
Yeah, that's wonderful. Actually, I appreciate you sharing this. Um, my two questions, well, one question, two components. The original MCQ that I did, the single best answer, I recall a lot of preparation and material on kidney transplantation. Is that not going to feature?
No, that is the beauty of strictly following the curriculum. So I will show you another document on the curriculum which I've already sent you in the WhatsApp. So
Yeah.
if we follow the curriculum, we know that what topics are tested in part one, what topics are tested in part two.
Okay. And
I'm pretty confident that they are very strictly following the curriculum. Of course, there will be a slight deviation, maybe here and there. The examiner may just ask you something outside the curriculum, but that may not be a significant factor in decision making of pass or fail, and that will not affect the result at any point. Okay.
got it. Okay. The other question I had was adrenal pathologies. Does adrenal pathologies feature in this exam?
Maybe, but again, in part two, it's very rare. Maybe in the whole 6 months program, what we are planning, maybe one day we'll just cover the adrenal pathology like adrenal cancer or something like that. But since it is not in this curriculum, it's not asked. If I'm correct, of my 10 years practice of running this FRCS part 2 courses, maybe remotely I may think one candidate said they have asked about the adrenocortical hormones and few other things, but that sometime may end up in technology, something in a different approach, like for example adrenal crisis, like for example
Mm-hmm.
urology emergencies. So it may come in different way, but not really like a patient presenting with ultrasound finding of suprarenal lump. How will you approach? It's not the scenario there.
Got it. Okay.
Okay, good. And so this is the curriculum. It looks quite like a busy slide, but just ignore this because we are going to discuss this separately in the next PDF which I'm going to share, which will be much more easy to readable. And so this is the booking parts, you know, the dates and those things. So this will be updated often, so you will be knowing the recent ones with the application fee detail, everything. And this is the link for our YouTube channel which you already aware of, isn't it?
Yes.
Yeah, so there is no need for you to do that. So it's always better to prepare in small groups, not necessarily now, maybe closer to the exam. It's nice to have maybe another one or two colleagues who are preparing for the exam. I will introduce one of my student to you, or even two, so that you three can work as a team. The only problem is the time difference which we are managing now, so there should be one way or another we can manage it in the future. And
Sure.
the YouTube channel Master the Medicine, now it is named as Master the Urology. Don't go to any playlist, just directly go to the playlist and use the playlist Urology Viva Preparation, because there are few other playlists for Pakistan board exam, Indian board exam, etc. So I don't want you to get distracted with the other board exams. And
Okay.
books, I will be covering it. Zoom Viva practice, what we are doing now. WhatsApp based discussion we do often, and then we do some timed mock vivas. Like for example, closer to the exam, at least we will do like a full viva, half a day, just like exam. You will be signing in at say 8:30, around 12:30 the exam will be over. You will be having the 8 scenarios done exactly in a 10 minutes fashion. So we will do a mock viva, almost exam based. By chance, if you're able to travel to UK closer to the exam time, I can book you in some of the face-to-face exam also. That will also give you a good real-time exam. We do conduct mock exams in few centers like Blackpool, Midlands, Bristol, London. So we will find some days which is convenient to your travel plans. So if you go to the actual playlist, so you need to go to the playlist and select the urology Viva preparation, that will be around 400, 500 hours of discussions happening. So you need to exactly select the Viva preparation ones for now. I don't think you need to go for any other Pakistan based board exams and those things for you now, since the focus is only on the exams. And this is one of the very standard book, slightly outdated now. I've done the chapter on BPH in the book, and by the time I wrote the chapter itself, a lot of new things like Eurolift, ITIN, Resume, or coming to the market but not build developed. By the time the book came as a printout, unfortunately, there are lots of new things happened in BPH, and the day one the book is released, it's already outdated. That's the unfortunateness of the printed books actually. But having said that, we are trying to have a book online which is gradually getting updated. For example, this is a 2023 edition. I won't advise you to buy it now. We will be having a 2025 edition, something around early January, and that will be having much more updated stuff, and that will be more suitable for your exam dates. It's a Master the Urology book available in Kindle or in Amazon. And apart from that, we will be touching various guidelines. That's more than enough, like AU guidelines, our own BOWS guidelines, and AUA guidelines once in a while. The weightage of AUA guidelines is very less, but nothing wrong in quoting it in few places. The big standard textbooks like Smith's Endourology, Campbell Urology, they're all not much used. To be frank, 90% of my students never touched these big standard books, and not necessary. But nothing wrong in doing it since you have enough time, and we'll see how far we can touch those standard books also. But predominantly, it's guidelines based and curriculum based. And as I said, the difference between international and UK FRCS is now completely ironed out. So maybe take another month or maybe a two to decide whether you're going for international or UK based. The UK based exam is a little bit more stringent, I'll say, while the international exam is slightly easier. But since you are in the program, I'm pretty sure we will be preparing you more than enough for even the UK based exam. So passing the UK based exam should not be a challenge. I won't ask you to avoid UK based exam just because of the increase in the challenge, but it's all individual. If you finish the UK based exam, then you feel a bit of a more complete and satisfied for your Caesar pathway, etc. Obviously, it has section 1 and 2 and gives you the eligibility for Caesar. And usually the exam is twice a year. So next one is in January, which you're not applying. You're applying for the summer 2025.
Yes.
So again, this is the 16 scenarios. I'm just putting it in a little bit of bigger font. So every scenario will be 10 minutes each. So there will be one scenario in BPH, one in andrology. So if you take this, for example, the BPH wise, there are some standard scenarios. Say, for example, 70-year-old man presenting with difficulty in passing urine. So it's predominantly voiding symptoms. You'll be heading towards IPSS, flow rate, examination, medications, tamsulosin, finasteride, and it fails, surgery. It's a very standard scenario. So that we call it as an index scenario. And from that index scenario, we will be having at least 5 to 8 branched scenarios. Sometimes patient may be coming with a pure storage symptoms. Like the only symptom is urgency and frequency in the daytime, and also getting up 4 to 5 times in the night. So you may be giving a little bit more weightage to lifestyle changes. Patient may head towards anticholinergic. Then the questions of, is it okay to give anticholinergics without alpha blockers? What is the safe in it? What is the evidence in it? And patient may progress towards anticholinergic failure, need for urodynamics, Botox, etc. So even though it's a BPH male scenarios, we may end up doing completely storage symptoms based scenarios. And similarly, andrology, there is an index patient, 30-year-old, fit patient, married for 5 years, 2 children, completed family, having difficulty in erection. You will be using IEF score to get to the bottom of the problem, indexing it, oral PDE5 inhibitors, and then slowly heading towards the surgical options. Then there will be some branched things, like for example, priapism, and something like patient coming with failed implants, and all those branched scenarios will be there in the andrology. And then similarly we can find like a index scenario and branched scenarios. The approach, if you do like this, the index scenario will give you a kind of basic. There should not be any mistake in the index scenario, because even the examiner will know that this is like an open book exam. Everybody know what is the index scenario. Okay, now with this kind of training programs and Zoom sessions, what we are doing, even people will know the branched scenarios also. No way you can complete the exam and come out and say, oh, I never expected congenital penile curvature. I never expected they will ask me about how MRI scan works, because now the curriculum is open. So this is like a, take it like an open book exam. Start writing the scenario, start writing your own notes. Of course we will be issuing what we are prepared till now, and prepare as if like you are going for an exam and you have something like 80 scenarios, and they're going to ask you within the 80 scenarios. So it's like an open book exam. And if you have this in mind, then you know at what level you are doing, whether you're going slow, whether you're going at optimal space. So it's a very easy, comfortable travel without compromising your family and your existing professional life also. So this one already you're quite aware of, and all the best for the exams. And you know the WhatsApp details, you've already joined me. So I will take you through the scenarios a bit later. Let's go through this syllabus blueprint. So I've sent this copy to you in your WhatsApp, so go through them in your own time also. So this is mainly for your Caesar later if you are going for a specialty registration application. So there are few ways by which they access, like CEX, CBD, DOPS, PBA, MSF. So example, PBA means like procedure based assessment. So like that, there are few things which you need to tick the boxes, which we will discuss it on a later day when you are going for a specialty registration. And then section 1, you are already quite aware of. The section 2 is the ISB examination, which is what we are planning to train you now. So in general, this section 2 revolves around the good medical practice, which will be quite straightforward. The knowledge is the one which really takes a lot of time to get to the bottom. Otherwise, rest of them you will be okay because of your already existing practice. And now here, for example, they will be discussing what is the outcome tested in which part. So in this document, just ignore everything like GCP, GPC self-assessment, MCR, everything including ISB section 1. Just ignore it and dwell only on ISB section 2. Okay, so that ISB section 2, whatever is marked, are we good in it? Say for example, the first one is manages an outpatient clinic. Most of your scenarios will start like a male patient, female patient, a child attending an outpatient clinic. So that will be checked in that format. Manages ward rounds, ongoing care in the patient. As I said, the patient with a scrotal swelling, the scenario may be like you are requested to see this patient in a medical ward. The patient got admitted due to some pulmonary embolism evaluation. So that's the ward and ongoing care of the patient. And slowly we are heading towards the other things like professional values, professional knowledge, and clinical skills. And then we are going into the actual basic science, anatomy, physiology. So there is no point in taking anatomy book like Snell's anatomy or something and reading it cover to cover. So you can read exactly what is expected in the section 2 and then read accordingly. So for example, they have marked here something like anti-reflex mechanisms. So this is the vesicoureteric reflex. So when you have a pediatric scenario with a vesicoureteric reflex, sometimes the question may be quite a theoretical physiology questions on what are all the mechanisms, how it works, in a neonate and a child on preventing vesicouretic reflex. So you will be discussing the intramural part of ureter and few other things. So why it is asked? Because it is in the curriculum and it is supposed to be tested in the part 2 exam. Similarly, if you go below, like for example into the dry science part of it, like audit and few other things. So how they test you on an audit or screening in a part 2 exam, they may ask about prostate cancer screening. So there will be a theoretical question on what is your view on prostate cancer screening. Obviously somebody can talk for 1 hour on prostate cancer screening, but you will be able to talk only 1 minute, because end of the day it's only a 10-minute scenario, and of which one question is on screening. So how quickly you are able to give your thoughts on screening in that, like a 40 seconds, 30 seconds, that's the main training. Okay, say for example, if somebody asks me, I will say still the verdict on screening is not completely clear. There are major studies like PLCO study and ERCP studies, and just take some major numbers and throw them, and then come to a conclusion that the UK based prostate cancer prevention program is got a very kind of a safe between screening and non-screening. So we are doing a very selective screening, like anybody above 50-year-old can get the PSA tested in the GP. Those who have high risk features, like for example ethnicity or family history, can start it right from age of 40. That's it. Just takes 30 seconds, 35 seconds, and ticks all the boxes. So if a question comes in the exam, believe me, it will be definitely on the back of this curriculum one way or another. It's a long, big one, but end of the day, that gives you a quite in detail thing of what we need to read. So there is a scenario on epididymitis, scrotal abscess, prostatitis. So you may be thinking sometime, oh, prostatitis is not that commonly practiced. Why they are asking? End of the day, just make sure that we are covering this curriculum quite detailed in and out. So for example, we thought of starting our whole discussions with stone scenarios. So again, in this document, go through the stone scenarios page and try to discuss everything based upon that. Of course, we will make some friendly discussions to start with, and we'll have some small mock vivas to cover the stone scenarios. Say for example, urinary tract trauma. Now, from this document, we need to read about trauma of kidneys, ureter, bladder, urethra, genital, testicular. So no way you can miss anything. Okay. So again, few things like they are not tested in the part 2. So they are tested in a different format. Like for example, how to insert a suprapubic catheter. So the examiner may not ask you the actual procedure, because it is supposed to be tested in a different format. Okay, so they will ask you about the cystoscope and insertion of JJ stent principles, like whether you do for that particular patient or not, or you will choose a nephrostomy rather than stenting for the obstruction. The discussion will be only that. There won't be a discussion like, okay, you have decided to do a stenting for this patient. The patient is there. How will you prepare the patient for stenting, and what will you do for stenting? What guide wire you use? Usually, they won't take you to the procedure, because it is supposed to be tested in a different format. But having said that, they can ask you the technology part of it, like if you want to do a stenting, what kind of equipments you will need. So you will say, for example, cystoscope, 0° one, and you will be telling the French, like for example, it's like a 20 French or 22 French or even a 18 French cystoscope, and maybe like one sensor guide wire and one extra guide wire if you need. What is a sensor guide wire? What the material the stents are made up of? How will you choose the length of the stent, like 24 or 26 centimeters? How will you choose the width of the stent, like 6 French or 4.5 French? And so those kind of technology questions may come, but not the procedural part of it, because it is tested in a different format. So overall, the aim is to make sure the particular candidate is good in the whole curriculum through various means, but our focus initially is to make sure we are ticking the ISB section 2 quite strongly. So that's why we are going to follow the curriculum quite strongly and take it from there. Any questions in this part?
Yeah, just a brief question. So you mentioned about equipment for a procedure and how, they won't directly ask me how I would do it, but there might be a roundabout way to go to test my ability and my safety to do this. Um, my only kind of question is there much variation between the kinds of equipment you use in the UK and what I would use here? Like, I would use a rigid scope with a 30-degree lens, and I would use a sensor wire, and I would use a 0.035 sensor wire, and I would use a multi-length stent. Now, could someone determine that they disagree with what your choice of equipment is, even though it's safe?
Yeah, this is the place where our previous discussion of taking an international exam will make you a bit more safer. Okay, I
Yeah.
won't entirely ignore this question with an answer saying that no, it's not like that. Wherever you are, urology is urology, so you should be fine. I won't say that. The reason is, if you think from the examiner's point of view, it's the same examiner coming for the UK based exam or international exam. Say, for example, I am an examiner. If I sit for the UK based exam on the day, my thinking process is okay, I'm going to test almost 40 to 45 candidates over the next 2 days, and all are UK graduates, UK based practitioners. So my mind will be quite strongly attached to things like, for example, Macmillan nurse or cancer specialist nurse and MDT and all those things. I will be quite strongly attached, and I will be expecting the candidates to answer, because I will be thinking that they are all practicing in UK 3 years, if not maybe for 10 years. And it's very rare for some non-UK practicing people like you to attend a UK based exam. But whether it will influence the overall pass fail, I will say no. I have got good experience of training Pakistan based and also, as you said, US based candidates for the UK exam. None of them had a fail pass scenario because of the answers what they say based on the regional practice. But having said that, it can give little bit of challenge here and there. Say, for example, if you say multi-length stent, it's not that frequently used in UK. So the examiner may say, what is the use of multi-length stent? Why are you choosing multi-length? Why can't you decide 24 or 26 centimeters definitively? So there may be some questions on that, but that will make your life a bit uncomfortable, but that will not influence the final result. Because the final result depends on the wholesomeness in the answers. Having said that, in international exams, say for example, if I am the examiner sitting in an international exam happening in Dubai or Malta or Sri Lanka or Singapore, I know that the candidates are not much exposed to the UK based stream of practice. So if they miss something like an MDT, I may gently nudge them that okay, you have done the biopsy for the prostate, it is now reported as Gleason score 3 plus 4, and almost like 7 out of 12 scores were positive. And instead of taking the patient directly to your clinic to discuss the findings, is there any way you can have a team input so that it's a bit safe and you can go through the radiology images in the kind of a shared setting without using the word MDT, so that if they come across like, yeah, we have our tumor board, so that may be one of the sentence used commonly in Pakistan. So I will discuss these findings in the tumor board and then take it forward, and they may not be using much of clinical specialist nurse in the clinic. And if a patient requires intermittent self catheterization teaching, or if a patient requires intermittent self-dilatation for post-urethral stricture teaching, those things will be done by the doctor himself. While in UK, the answer will be like, I will make sure the patient is seen by my benign LUTS nurse so that they will teach them on the techniques. So these subtle differences, but the long story short is it will not affect your outcome, pass or fail, but it will make the travel little bit jiggery here and there. And but once you speak to us continuously, especially when I link you up with some of the local UK exam going candidates, especially the month or two before the exam, you will get so used to that because the difference is very minimal, so you will get used to that. Okay.
That's reassuring. Yeah. Okay. Thank you.
But these things you need to take it seriously because you are still have the ability to decide a national or international exam. So that's why it's better to think about these things quite clearly now.
Yeah.
Any other questions?
No, I think from my perspective, I need to really look at that blueprint, that, the syllabus
Yeah.
thoroughly in detail, because I know it exists. I knew it exists, but obviously, like you mentioned, I've prepared the kind of the old-fashioned way with the books and the texts and the guidelines.
Yeah. So the main thing is it's not a bad practice, but the issue is, say for example, if they are asking about what is enoxaparin, what are the components of enoxaparin, or what is bridging therapy, what is the physiology behind bridging therapy, warfarin, and the newer anticoagulants like rivaroxaban or indoxaban, something like that, then the candidates will get confused why they're asking those things which we don't have to read to that extent. Okay, I know there is a technology scenario where the questions are only on medications like gentamicin, ciprofloxacin, nitrofurantoin, how it works, and gentamicin works in the DNA based one. What is the spectrum? How much it covers the aerobic, anaerobic, and gram positive and gram negative, because it is in the curriculum. So once you know the curriculum, even if you are not prepared, at least you know that okay, at least from the exam point of view, they are not really like selectively asking me some difficult questions. It is in the curriculum, so because the questions are selected even before you reach the table, so they will select a question scenario, and once you reach the table, it's for you. So none of the questions are selected for after seeing the candidate's face. So there should not be any bias, and there should not be any unnecessary thinking like, oh, they've selected the scenario after seeing me, and something like that. The questions are not targeted with you. The questions are prepared, and once you go and sit there, they will deliver the question. And we will go into this examination techniques quite closer the date. Now, how we are going to run this show is, as I said, now I'm going to give you a few more days to get yourself nicely grounded on the stone based scenarios. You can use this curriculum blueprint to go through what type of scenarios are possible. Every time I will send you recorded our own YouTube links on that particular scenario. Say for example, I will send you the stone scenarios after the session today, so that you can use this as a kind of your groundwork to, I mean, end of the day, if you are able to reproduce exactly the same answers, that's more than enough. But then it becomes like a spoon feeding, so we don't want to do that. So end of the day, after going through that, next class when I am running a 10-minute scenario, when I'm asking the questions, you should be able to answer the same things in your own word, in your own comfort, possibly with some more upgrading. So every answer, any answer can be upgraded. There is always a scope or the space to improve further. And even if you upgrade it now, when we are going for the second, because our aim is to do the whole 8 tables into 16 scenarios at least twice, if not even thrice. So when we start stones maybe from the next class, and then maybe finish the whole stone scenarios in say 3 weeks time, after finishing the whole 8 tables, we will be touch base on the stones again something around April. So the expectation in April is you will be much more confident in answering the questions, because it's almost like a revision. And closer to the exam, as I said, there will be at least 2 or 3 full day mock, just like exam. All the 8 tables, all the 16 scenarios, exactly 10 minutes over half a day or even more than half a day. And if you're able to travel across Atlantic, we can plan something face to face also. And so this will keep you absolutely certain about the outcome, which is pass. That's what we are expecting. And the secondary outcome of good curriculum coverage and good confidence in the practice, so that you can apply it with your colleagues and patients throughout your life. Okay.
Yes, understood.
Good. So that's the methodology. I will send you some stone scenarios now so that you can read through over the next few days. We will try to do once in a week session on an average. So some weeks we can do even 2 sessions, and some weeks we can have a break if you are traveling or if I am traveling. and we'll take it from there. Okay,
Yes, perfect.
good. Any other questions before we stop today?
Nothing. No, thank you for your time. I think I'm looking forward to it. When you when you mention, I have this. There is a bit of a confusion in me. Unfortunately, it's like, well, should I take the international? Should I take the domestic? I don't feel as international because I grew up in the UK. So when I think about these things, I grew up in London and I left London when I was 18. So my vocabulary and my speech is very much consistent with the UK, but I guess my medical language is perhaps more American. So I'm kind of conflicted as to which one would be best for me.
Yeah,
And perhaps in
regarding
about
that, regarding that, I don't want you to decide straight away in the session now, and so dwell on it, sink into it. Maybe next time when we are discussing, let's discuss this so that you have some time for whatever we discussed now to sink into you. It's always, this is a big decision, so I don't want you to make it the decision now. Okay, just think
Yeah,
over it, and you'll be having enough time to think about it. Okay,
no problem.
good.
Thank you.
All the best.